Hi, everyone. We are going to be looking at chapter 15 today, which covers eating disorders. A lot of information in this chapter as well, but some major points I want to stress. The chapter begins with a focus on kind of the why. Okay, so how does this happen? Why do we have problems with eating disorders and disordered eating in this country? And certainly media is part of this, but one piece of the puzzle for sure. There's a lot of attention to image, especially now with social media, perfection, being able to create that. And what gets blurred a bit is the difference between reality and between those creations of unreal images. So it all is a stress and a strain, and for some vulnerable individuals can result in disordered eating. Remember that food is a source of nutrients, but it's much, much more. It's a source of comfort. It's a way for some to respond to emotions. There are very real changes in the brain that occur after eating food that can give us a sense of calm. We know that if we use food as reward beginning early in life, or a bribe, as a matter of fact, that this can lead to disordered eating, and that disordered eating may require professional intervention if it is sustained, interferes with everyday activities, and leads to some health issues. Many eating disorders start with a diet, and that diet goes awry, but not all dieting leads to eating disorders. Keep in mind that eating disorders are psychological diagnoses, okay? A few are listed here: anorexia nervosa, bulimia nervosa, and binge eating disorder, and we'll look at a few more as well. Genetics plays a part in this, but so does environment. And here again, I want to make the point, there's a difference between attention to eating for good health and maybe losing a few pounds and being attentive to that, and then disordered eating, when dieting becomes very restrictive, when it tends to take over someone's life. In the past, okay, decades ago, eating disorders were a young white woman's disease. And now what we're seeing, unfortunately, is that eating disorders are crossing ethnic and cultural groups. They occur throughout the life cycle, although they're more frequently noticed or diagnosed in adolescence and young adulthood. And they occur in all ethnicities and cultures, and men and women. 90% of anorexia and bulimia cases are women, however, and this is believed to be due to the fact that women are held to standards that are unnatural in terms of their physique. But keep in mind that 10% of those cases are men, and 40% of binge eating disorder cases are men as well. We'll talk about athletes later in this presentation. So these are the three main categories: anorexia nervosa, self-starvation; bulimia nervosa, binging, followed by purging; and then binge eating disorder, binging without purging. All of these main categories of eating disorder have health effects, physical effects, and you can see them here. Some are easier to note on a clinical exam than others, but take a look, be sure to read through. For anorexia nervosa, we see a lot of these physical effects due to starvation. Bulimia nervosa, a lot of the physical effects are due to the purging, and in binge eating disorder, due to the excess of calories. So a little bit of a focus on anorexia nervosa. The three characteristics are extreme weight loss and an irrational fear of weight gain. Somebody flipping out because they notice a little salad dressing in their bowl, for instance, and a distorted body image in that this individual sees themselves as a healthy or overweight when they are very, very thin. Here are some of the behaviors. They may have a list of safe foods, extreme dieting, they drive for perfection. They also can have some compensatory behaviors, such as vomiting or excessive exercise. In nutrition therapy, there are goals of weight gain, prevention of further weight loss, increase in food intake, certainly, and appropriate food habits. But I would like to mention that the main professional in the recovery of someone with anorexia is the psychologist or the therapist, because they need to dig into the underlying emotional problems and show the individual how to regain control in parts of their life that they don't feel they have control over. There really are no FDA-approved medications for the treatment of eating disorders, and medications are generally not effective. But sometimes these individuals have mental health issues as well that medications may help. And I want you to note recovery rates there. This is important. 20 to 30% of those who have short-term therapy recover, but 70 to 80% with longer-term therapy. This is a lifelong battle for most people with anorexia nervosa. Now, bulimia nervosa is binging and then purging. Much of this is a hidden disorder. Weight is not skeletal, as you see in anorexia nervosa, but you'll see someone who is a healthy weight or even overweight. So this behavior is done in secret. Now, women are the primary population with bulimia nervosa, but 10% of cases are men. And this individual is known for impulsive behaviors. So their purging is hidden, and it can involve forced vomiting. It can involve excessive exercise as well. And the cycle looks like this, where somebody feels anxious, they go to food, they fear the fat gain, and they purge, and they then feel guilty, and it goes around and around again. Something that's interesting and important to use as part of your counseling and education is that up to 75% of calories are absorbed after vomiting, and 90% of calories are absorbed when laxatives are used. So even though these are damaging physically, they aren't that effective for canceling out calories. That can sometimes discourage individuals from using these destructive techniques. The effects of the bulimia primarily come from that purging. We see dental decay because of the acidic wash over the teeth. We see calluses on the hands due to the forced vomiting and the scraping across the teeth. That's called Russell's sign. Sometimes we see swollen salivary glands. Sometimes we see electrolytes out of balance as well. Treatment involves nutrition and psychology. Psychotherapy is very important as part of this, and antidepressants may be indicated in some individuals. Now, binge eating disorder is different because it is the binging without the purging, and 40% of these cases are men. What happens is there's a knee-jerk reaction to a stressor, And this leads to food and consumption of very large categories or quantities of food, typically in the category of junk foods. Treatment can be effective, and the goal is to eliminate episodes of binge eating, and also, because these individuals are overweight or obese, to lose weight and help them be healthier as well. Psychology is the mainstay of treatment for all of these eating disorders. What we want these individuals to do in nutrition therapy is learn to eat in response to hunger rather than emotional needs. So paying more attention to mindfulness and paying attention to cues is very important. We also want them to avoid deprivation style diets, because that can again trigger binge eating. There is a medication, Vyvanse, which is a stimulant used to treat attention deficit disorder, which has also been approved in 2015 for treating binge eating disorder as well. So I'm going to kind of quickly go through some of the other eating disorders. Pica is one. We will talk about this during pregnancy, but pica occurs as a primarily mental health concern in other cases. So this is consuming non-food substances for a period of time, and this can cause gastrointestinal blockages, poisoning, infections, so it can be very serious. Subthreshold eating disorders are when you don't quite meet the criteria for a diagnosis, but there are still disordered eating there. Purging disorder is another, where an individual repeatedly purged, even in the absence of binge eating. Night eating syndrome is eating 25% of your calories after that evening meal. Sometimes people wake at night to eat, and they feel incredibly depressed and guilty about this. Now, relative energy deficiency in sports has taken over from the female athlete triad for the most part, because this can involve men as well as women. This is when energy is not adequate for all of those calories that are burned in sport, and because of that, it can impact metabolism and the immune system and mental health as well. It's more common in sports with weight classes, or when being thin is somehow an asset in that sport. Because of this, physiological symptoms occur. And in women, what we see quite often is amenorrhea because of a decreased production of sex hormones. The female athlete triad is REDS for females. So what we see here is inadequate energy intake to match that high energy expenditure. And when this happens, you cannot produce the hormones as you should, and amenorrhea, or a stopping of the menstrual cycle, occurs. And because of the low estrogen levels, there's a problem with depletion of bone mass, and there can be bone breaks as well. So therapy, of course, is to match those needs, to make sure that the individual is consuming enough calories to match their training, and it might require some decrease in training as well. And because we want to protect the skeleton, to make sure there's enough calcium and vitamin D on board. Muscle dysmorphia is another disorder, and this is reverse anorexia, when the obsession is with getting bigger and bigger and bigger to the point that it crowds out the rest of this individual's life. There are problems with patients with type 1 diabetes using skipped insulin doses to cause weight loss. If you remember back to our study of diabetes, when blood sugar goes too high, that spills out into the urine. So what happens is some young people may use skip doses to induce weight loss. Orthorexia is when healthful eating becomes an obsession. So what we're seeing here is someone who perhaps began by just wanting to become healthy, but then it takes over their lives. So their need is for perfection. Forget the 85-15 rule. This is 100% rule. It's not necessarily a drive for thinness. It's a drive for a perfect diet, and it may be related to obsessive compulsive disorder. So this may be the most important part of this presentation, and that is, how do we prevent these eating disorders? If they're crossing cultures, if they're crossing age groups, what do we do? Well, restrictive dieting and meal skipping should be discouraged. Young people should know what normal changes across puberty look like, and certainly weight gain is part of that. Myths need to be corrected, and so do recommendations need to be carefully worded, and we don't want to overemphasize weight. We want to emphasize health, and we also want to be sure that young people have a place to take their emotions and a way to handle their emotions. We need to raise children who are encouraged to eat when they're hungry, and provide adolescents with some control and choice over their diet. And also, very, very importantly, to increase self-acceptance about their bodies of all sizes and shapes. We should enhance tolerance and build respect. We talked about this with weight stigma. Build respectful environments for people of all shapes and sizes. If we have young people who are very interested in sports, they should also know that this restrictive dieting could come back to them with a decrease in performance instead of improved performance. Okay, so thank you. Have a great day.